Hi, this is Brian Kim. I want to share with you this case of a patient who's referred for recurrent vitreous hemorrhages and suspected UGG syndrome. This patient had cataract surgery done elsewhere and had a single piece of acrylic lens within the capsular bag. And this patient had recurrent vitreous hemorrhages and uncontrolled glaucoma. The surgeon very astutely determined that this could be an UGG syndrome. And so when I saw this patient in the clinic, first thing I noticed was there's a distinct transillumination defect in the exact shape of a haptic. And so again, you can have UGG syndrome with a single piece of acrylic lens within the capsular bag. And people who think that the lens has to be outside of the bag or malpositioned is really incorrect. You can have UGG syndrome even if there's a lens within the bag, especially if it's a single piece of acrylic lens with squared edges. Those thick haptics, they tend to rub on the posterior aspect of the iris and can cause UGG syndrome even though the lens is in the bag. As I jiggle the eye, you can see there's some IOL denesis and there's quite a bit of vitreous hemorrhage as well. I'm drying the surface of the eye and then inking the limbus with a 27 gauge cannula on the right side and then the left side using the shaft to find 180 degrees apart. And then this is a fixed caliper by Epsilon. I don't have any financial interest. And I'm indenting the sclera 2.5 millimeters posterior to the limbus and then 2 millimeters adjacent, and then inking those marks with a 27 gauge cannula. Do the same thing on the left side, again using the fixed caliper, indenting the sclera, again 2.5 millimeters back. In this case I did it, but then I really didn't see that distinct mark. My assistant inadvertently actually inked the tip of the caliper, which is not the way I do it anymore. Again, I like to use the 27 gauge cannula to ink. Using the back end of the 4 millimeter trocar, indenting 3.5 millimeters posterior to the limbus. And then using the cotton tip, I'm turning the eye, pushing the eye away from me, stabbing the sclera and conjunctiva 3 millimeters away from that indentation, tunneling 3 millimeters, and then diving down perpendicular. You can see that the cannula is sitting sideways, which again gives me a better chance of having a self-sealing sclerotomy. These are my limbal incisions, first on the right side, and then my contralateral limbal incision to externalize the leading haptic, as well as for my AC maintainer. And this is the incision on the left side to help me explant this lens. You can see there's so much vitreous hemorrhage moving around as I'm moving the eye. This is some intracameral epinephrine, just pulsing just very gently. And this is some dispersive viscoelastic to coat the corneal endothelium. This is the 3 millimeter blade. I make a vertical groove, tunnel through the cornea, and then enter. So using 2 forceps, I'm going to try to get after this lens. I have the serrated tooth forceps, the IOL holder in my left hand. With the teeth closed, I just lift the edge of the optic with the right hand forceps, grabbing the edge on the left side as well. And once I have the left side secure, I'm just retracting the iris and lifting the lens bag complex up. You can see there's a Sommering's ring. And the first thing I'm going to do is make sure I pop the ring up. You want that lens material in the anterior chamber. I don't want it underneath the IOL, because if it's underneath the IOL, there's a chance that that material will fall into the vitreous space. So before I let go with the left hand with the IOL holder, I'm holding it tightly with the left hand and using the right hand forceps to bring the Sommering's pieces up into the anterior chamber between the lens and the cornea. And then I'm repositioning the lens so I can cut it in the orientation that I prefer. I'm cutting about 90%, and we're going to Pac-Man this lens out. Again, with the single piece acrylic lens, it's fairly easy to pull each piece out. I'm going to grab the cut edge on either side with each forceps, pulling the right side piece out first, letting go with the left hand, twisting the lens, again because it's a Pac-Man, rotating it now 180 degrees, and then pulling the second piece out. Because I had the Summerings ring above the lens implant, it's still in the anterior chamber. Going to push some dispersive viscoelastic beyond the lens material, and as I push, I'm able to sweep that Summerings ring towards the main incision, pushing viscoelastic in and then pushing down on the wound to burp the Summerings ring out. This is a 22 gauge thin-walled AC maintainer by Epsilon. Again, I don't have any financial interest. Placing it into the eye, which will help me get ready for the pars plana vitrectomy. Checking the wound, and lo and behold, again, there's absolutely no vitreous during any of these maneuvers. Again, it's been my strong experience and opinion that in these cases of late IOL dislocation, there's such severe vitreous liquefaction. That's the reason why the lens falls, and therefore there's not much firm vitreous in these situations. And so taking the lens out first is really not that big of a deal. And I prefer to do pars plana vitrectomy after the lens is actually out in these situations. So again, no vitreous to the wound, which is evidence to my point. Taking the bubble out, performing the vitrectomy, you can see there's so much vitreous hemorrhage. Look at all that stuff coming out through the vitrector. And what's also interesting is because all of that viscoelastic was pushed into the anterior chamber, you can see that I do have two compartments. You can see the bubbles in the anterior chamber. You can see the reflection of the viscoelastic that's coating the cornea, and there's clearly no vitreous in the anterior chamber, and so I'm able to do pars plana vitrectomy in the anterior space, getting rid of all that blood and making sure I'm doing vitrectomy just underneath the areas for my scleral needle placement. This is a 25 gauge needle to externalize the leading haptic. I bend the needle fairly close to the hub. Again, the needle bevel is facing to the right. This is the right side thin-walled AC maintainer. I'm bending it about 9 millimeters from the tip, bending it in such a way that the bevel is going to face the main incision. And this is the left side needle I'm bending at the hub, making sure the bevel is going to face the contralateral limbal incision. This is the cartridge for the emerald lens. I'm placing cohesive viscoelastic into the barrel as well as the platform, placing the Sensor AR40 lens onto the cartridge. And when I place it onto the cartridge, I'm going to make sure that it is seated into the lens. And you know this because I'm going to do a side-to-side wiggle, and it's very smooth, and you know it's deep inside. I bend the wings together, and as I do this, the optic bends backward. The leading haptic comes out straight through the barrel, and the trailing haptic comes out through the back end. I place the lens into the injector, and I want to make sure that the trailing haptic is up outside of the barrel, and then I could advance the plunger, which will be safe and it won't damage the haptic, and advance the lens. Okay, here we go. This is the 25 gauge needle. It's going to go through the contralateral limbal incision for a passive docking technique to externalize the leading haptic. The needle bevel is facing to the right. The injector bevel is facing to the left. As the lens is being delivered by my assistant, the haptic comes out. I dock the leading haptic onto the bevel of the needle, and I turn that needle to align with the haptic. As she advances the lens, more and more of the haptic goes into the needle, and then I pull the needle out, and the haptic is effectively outside the eye. I take over, and now I deliver the optic so it comes out straight, and then I sweep the trailing haptic, or make sure at least that the trailing haptic is facing to the right, making sure that the AC maintainer is not getting snagged on the lens, using some dispersive viscoelastic to coat the cornea again, and repositioning the lens, holding the trocar cannula with forceps, stabbing the conj and sclera at the first mark, turning on infusion. So I do that again, stabbing at the first mark, flattening out, staying flat, tunneling 2 millimeters through the sclera, and then I dive down. I want full resistance throughout that 2 millimeters as I tunnel the needle through the sclera. Resistance the entire time. Very important to get that shelf. pulling the leading haptic outside the eye, pushing the optic away, sliding the trailing haptic into the eye with minimal stress on the haptic. I'm going to dock the haptic on the bevel of the needle. And this is an example of when I'm not completely aligned. And you can see I'm struggling a little bit, but that's okay because I have full control. Again, the leading haptic is outside the eye, the optic's pushed away. I have a lot of room to work on this. You don't see any unnatural bending of the haptic, unnatural twisting of the haptic. I'm not manhandling the haptic whatsoever. I'm just being patient. And then finally, I dock the haptic on the bevel of the needle and 2 pushes and I'm in. Disengaging the needle from the syringe. Letting it down and then pulling the leading haptic into the anterior chamber. Turning on infusion. And then I'm going to do contralateral fixation. Again, you want opposing forces when you're passing the needle, because if you don't, then the conjunctiva will move. So I'm holding the eye contra-incisionally, repositioning the conjunctiva because this patient has quite a bit of conjunctival chalasis, stabbing the conjunct sclera at the first mark, flattening it out and staying basically parallel to the scleral surface, tunneling 2 millimeters, and then I dive down, facing the optic nerve once again. Turning the needle to face the haptic and not the other way around. As you can see, this iris is rather floppy. Some of the iris is coming to the wound, but that's okay. If there's too much iris coming out, I can stop and turn off infusion if I need to. And you're going to see here, this is very important. I'm actually going to stab the haptic into the needle and it gets wedged in. So I have to disengage it and then try again. So look, let me show you again. I try to advance, I'm stuck, I'm not getting anywhere, and that's because the haptic is wedged into the needle. So in here, I'm going to withdraw, pops right out. You saw that sudden popping off of the haptic from the needle. I dock the haptic on the bevel of the needle again, and it goes right in. So again, that is what's happening in these situations. The PMMA haptic of the Sensara lens is soft, and if you're not careful and you're not fully aligned, you'll be actually stabbing the haptic into the edge of the needle and it gets wedged in there. Kind of like when you're cutting a tree with an axe and the axe gets wedged in the tree. So the only way to do that is not to keep jamming, because if you keep jamming, you're just going to bend the haptic. It's not going to go forward. You got to pull back on the haptic, and you saw that sudden pop off of the haptic from the needle, and I was able to redirect, dock the haptic once again, flatten out, and it went in with 2 pushes. Pull each needle out just a little bit, pulling the left side needle all the way out, minimizing how much haptic comes out, and then cauterizing the tip. Doing the same thing on the right side. Again, I'm limiting how much haptic comes outside the eye. By doing it that way, I'm going to minimize any undue stress on the optic-haptic junction. This is really, in my experience, the best way to minimize any stress on those delicate PMMA haptics using my modified technique and all of these very important nuances and pearls to execute the surgery properly. I didn't get quite the flange I wanted on the left side, so I'm drying the eye a little bit more, and then I'm cauterizing one more time. You can see that both haptics are nice and flat, and that means I have a nice scleral shelf. The haptics are not pointed up. So therefore, if I have a good scleral support, this lens should mimic in the bag IOL placement, and therefore I should have a pretty good refractive result as well. Pushing the haptics flush to the sclera, burying the flanges, reapproximating the conjunctiva, and then closing the main incision with the tenon suture. As I turn on infusion, look, there's a little bit of reverse pupillary block with optic capture inferiorly. And so this is what I'm going to do. First, I'm going to do my temporal surgical PI using my setting. I'm going to do a vitrector assisted PI. And again, you want to make the PI similar you would with a laser. You don't want to go all the way to the angle because this can cause ciliary body bleeding. But look, I'm going to place another PI in the area of the optic capture, right there, inferiorly, infranasal, making a PI in this area. And as I do this, lo and behold, it releases the optic capture and the pupil comes down nicely. So that's another pearl. If you have a little optic capture and you know that the lens is in good position, it's not because of a bad lens position, you can perform a surgical PI in the area of the pupillary capture. Did some pars plana vitrectomy, and then using the vitrector, I'm just removing the viscoelastic on cortex mode in the anterior chamber. Look how much flopping of the iris is occurring with this. This is really very interesting. I do think that these cases are the ones that end up with optic capture or reverse pupillary block or something unusual. Look at the infusion pressure. As I'm just putting the infusion pressure, look at this iris moving around, billowing. There's quite a bit of IFUS in this case. And so you can imagine if you don't have a surgical PI, you could have reverse pupillary block. You can get pupillary capture of the optic. You can have a lot of these strange phenomena that occur in these situations. But performing a PI, and in this case, not just a temporal one, but a nasal one in the area that I had of pupillary capture, this should minimize any potential future capturing of the pupil to the optic. And after this, I'll just take the trocar cannula out, the AC maintainer out, and then I'll hydrate my incisions. So again, this is a patient who had UGG syndrome from a single piece acrylic lens, as well as recurrent vitreous hemorrhages. You know this was UGG because when you try to retroilluminate, you can see nasally that the haptic transilluminated all the way from the optic all the way to the periphery. Again, it's a misconception that UGG occurs in dislocated malpositioned lenses. This is a lens that was in the bag, so it's not just for those situations. You can have in the bag IOL, but because of the fat and thick single piece acrylic lenses and the square edges, I think in these situations when you have poor zonules as well, you can get anterior movement of the lens bag complex and then rubbing of the posterior uvea, causing UGG syndrome and recurrent vitreous hemorrhage. So I grabbed the lens using 2 forceps, popped the entire lens bag complex into the anterior chamber, making sure the Summerings ring was above the IOL, which will protect it from falling into the vitreous space. Again, by pulling the Summerings ring up into the anterior chamber, I was able to cut each lens piece in a Pac-Man configuration, explanting the right side piece out, and then turning the lens 180 degrees and then pulling the last piece out, burping the Summerings ring out with viscoelastic, placing the 22 gauge thin-walled AC maintainer, and then using my technique of externalizing the leading haptic using a 25 gauge passive docking needle technique, and then docking the haptic on the bevel of the needle on the right side first and then the left side. Again, by externalizing the leading haptic, I have better access to the trailing haptic, which was so easy. And you saw in this case, when you're not completely aligned, as you try to push the haptic into the needle, you can actually wedge the haptic into the sharp edge of the internal aspect of the needle, and then you're stuck. And if you push, you'll damage the haptic. I really believe that's what happens in a lot of the people who have failed using the sensor lens. And that's wedging that PMA haptic into the needle is like wedging an axe in a tree that you're trying to cut. You just have to withdraw the haptic and then start over. And you saw that executed perfectly. Again, a nice flat approach, tunneling the needle through the sclera 2 millimeters. Again, this best mimics an in the bag IOL placement. And this person did very well. Post-op day 1, this patient had 20/30 vision, uncorrected, very happy with the result. He noticed immediately that all that blood in the vitreous space was much improved. And we'll see what he looks like after his suture is removed and at his 2-week post-operative period. So I hope this was helpful to you, and I thank you for your attention.